some of those issues and take specific votes as we have them teed up. So why don't we move to the next slide to show the first vote. And just to be clear, the patient population for all these questions is adults with moderate to severe COPD on maintenance therapy. Maintenance therapy, we know we'll be talking about this some more, but it is defined here as LAMA, LABA, combination therapy, or combination therapy with inhaled corticosteroids. All right, let's go ahead and talk about the clinical evidence behind the first question. Is the current evidence, with that patient population in mind, is the current evidence adequate to demonstrate that the net health benefit of ensifentrine added to maintenance therapy is superior to that of maintenance therapy alone? All right, don't vote yet, but those are the two options, yes or no. And I'm going to invite Grace Lynn again to just review the key ICER kind of findings, the table with the data, and then we can kick into further discussion. Grace?
Thank you, Steve. So as Steve mentioned, just reviewing what I went over this morning. So ensifentrine added on to maintenance therapy. The data from the two clinical trials, ENHANCE-1 and ENHANCE-2, demonstrated that ensifentrine improves lung function in mean FEV1 and other measures of FEV1. It reduces the annualized event rate of moderate or severe exacerbations with a relative risk of 0.60. It increases the time to first exacerbation, hazard ratio of 0.60. It has a mixed effect on quality of life, with some scales showing improvement and some patients responding with exceeding the minimal clinically important difference. And then its harms are relatively minimal in terms of ensifentrine versus placebo, similar harms in both groups. There was a large withdrawal rate, largely due to COVID. And so that is one thing to keep in mind in terms of the trial characteristics. And then finally, in terms of subgroups, we did not see any effect modification by subgroup, in particular by background therapy. And so we had we gave ensifentrine a evidence rating of B+ based on that data.
Do you mind thank you. And those, by the way, the tables in the evidence summary are tables 2, 3, 4, it's like 5, 6, 7. I'm not sure what page it is in that document, but just for CEPAC members who have that, that's where you'll find it. Grace, do you mind just a tiny bit more when you say no effect modification? The question has already arisen in the conversation, but what about the people who are on combination therapy? They weren't in the trial. They were prohibited from being in the trial. So what do you mean by no effect modification by background therapy?
So the groups were the LAMA only versus LABA only versus LAMA plus ICS or LABA plus ICS groups. So we did not see the effect. There was the trials weren't powered to
Right.
look at this, but from the data that we did see, we did not see a difference in effect in these different categories of background therapy.
What about patients who were on no background therapy? There were a fair number actually in the trial, right? No effect modification there either?
Not that we saw. Again, the trials weren't powered to show this, but we did not, we did not see it that.
Okay.
About 40%.
Sorry.
I was just going to give the numbers. So if we're talking about the exacerbation rate ratio for people on no background therapy, it was a 43% reduction. On LABA, it was a 34% reduction. On LAMA, it was a 33% reduction. So you're not seeing much to suggest that it makes a big difference.
Okay. Thank you. I think that's helpful. Myself, so let's turn it back over to the CEPAC. Questions and discussion. Remember, you have the clinical experts and the patient experts at your disposal. All right, I'm going to prompt you guys a bit. Who is thinking that as they weigh this evidence, they're likely to vote yes, the evidence is adequate. Would they like to present some of their thinking behind how they're putting this all together?
Albert's
Oh, I
got
see a hand. I see a hand with Albert. I'm not sure if you're answering my question or if you have your own, but go ahead.
I might do both.
Okay.
So I am likely to vote yes. But I would love if Grace or someone could put the risk reduction in terms of real, like kind of raw, like real term, like are we talking
Absolutely.
about like going from 4 exacerbations a year to 3 or 2, or in raw numbers, what would it mean for a person?
So so the definition of moderate to severe COPD, there's the different categories of the ABE where you have more than 2 exacerbations, moderate to severe exacerbations per year or less than that. And in the trial, we had, I believe, it was 60, almost a 60-40 split in terms of moderate and severe exacerbation. So I have to look, and maybe one of the members of the research team can help me about the raw number of exacerbations, average number of raw exacerbations per year, but I believe it was somewhere in the neighborhood of 2.
Yeah, I saw that in Mel's numbers actually as well.
0.8, yeah. So, it is, now keep in mind, this was a younger population and about a quarter of population did not have an exacerbation in the 15 months prior to being in the trial. So this trial population is likely not as sick as the population that this is likely to be used in. So I will defer to Dr. Christensen and Dr. Rojas to sort of maybe give you some more perspective on the real world population. But in terms of the trial, they had not as many exacerbations as probably real world.
Juan or Stephanie, apologies if you don't mind my using your first names, just for ease. Any comment you'd like to add to the question about the exacerbations as background in terms of understanding the population involved in the trial?
I don't know if Juan wants to go, but I can say that probably it would be, it's hard to say exactly what, like I think we could use this in either the kind of symptomatic without exacerbation population. So gold group B, which would be, to try to see if there's symptom improvement versus in the gold group E group, which would be exacerbations with or without symptoms. And yeah, I think probably, again, COVID may have played a role in low exacerbations, but I will say typically, particularly in a pulmonary practice, these exacerbations rates were rather low for what we normally see. And some of that may have been driven by kind of a healthier patient population than what we would probably normally use this as add-on therapy for.
Thank you.
Yeah,
By the
I would
way,
agree with those comments.
sorry, Juan, go ahead.
Yeah, I would just say that, I think to Albert's question about like a real world number, that I can only speculate, but I think, if you could tell someone that you might have a moderate or severe exacerbation 1 less a year, that might be meaningful enough for someone to think about nebulized therapy daily.
All right, Juan, we're having a little bit of difficulty hearing you through whatever method you're using. So I don't know if it's moving it closer or shifting the angle or something, but we caught most of it, but it was a little bit difficult. Okay, let me go ahead and go to David with your question or comment.
Yeah, I think I'm still along whether this trial population is really representing the real world populations in terms of practice patterns. So if any experts can share a little bit more details about in the real world populations, how many of the population or proportional populations that could be no maintenance therapy. And then among those who own the maintenance therapy, how many of them actually are, consistent with the trial inclusion criteria with like monotherapy with the ICS. So I'd like to really know the size of the matching populations between trial populations and then the real world practice pattern.
I will just caution the clinical experts because it's all what you see as academic experts in a tertiary care center may not be what is out there in the quote unquote real world. So please feel free to comment on both, but I do think it's important for us all to remember that your patients probably don't reflect, the average community profile.
Yeah, I was almost going to say kind of that. I will say, where is ensifentrine going to be used? I'm guessing mostly by pulmonologists because it's a nebulized therapy, although it could be used by primary care where we would maybe see a lot more patients not on anything. But as far as seeing patients on LAMA alone or LABA alone, I think it could be still pretty substantial. I will put everybody on LAMA LABA, but I will also say that those guidelines changed in 2022. So where a lot of our patients in these populations would have been started on a monotherapy. And so it's hard to know, it's hard to say kind of to extrapolate, okay, how many of those would have been actually on a LAMA LABA if we like in 2024 that in 2022 was on just LAMA or LABA alone. So I think I think it's probably and I hopefully maybe others can, based on like other real world extrapolated data, can give you those numbers. But I think I put people on LAMA LABA, but I'm always still teaching my fellows to do it. So I don't know that it's a completely like that everybody's doing that.
And David, I know, or Grace, the issue of, again, what background therapy we should be thinking of when we're talking about a net health benefit, that's come up at multiple points in time. And you already kind of gave the rationale behind the B+ as opposed to a C+. Do you want to revisit that again, just in terms of commenting again on how your own thinking about which patient populations we're thinking about here? And that's why I mentioned the kind of relative effects in subgroups, but do you want to revisit that briefly, either David or Grace?
So I'm happy to describe sort of how we had lots of discussions about this. I don't think it was really B+ versus C+. It was B+ versus C++ up to the substantial. So if you look at the ICER evidence matrix, which I think you all have in your packets, a B+ says it goes from basically a small benefit up to a substantial benefit. And a C++ says it goes from no benefit up to a substantial benefit. And it's a question of how uncertain you are. Let's imagine that this hadn't happened during COVID and you had about 1,500 patients randomized and a 40% reduction in exacerbations, and it had all the correct background therapy. You'd be nudging up on an A there for a therapy that has no harms, right? We'd be pretty sure of a substantial benefit. I think that the COVID bias of people dropping out probably biased against the therapy, but it might have biased in favor of it. And so you have to count that in your uncertainties. And then you have to say, well, it had the same relative effect in no background therapy, LAMA background therapy, and LABA background therapy, as best we can tell. What's the likelihood that it has not even a small benefit in people on LAMA LABA? We thought that was pretty unlikely given the data we had. And so that got us to the B+. It was that given the groups looked at, the chances that it had no effect in the right direction on LAMA LABA with a 40% reduction in exacerbations in each one seemed unlikely to us. And that's how we got there. But we debated it. So we could imagine that some or all of you might decide that there isn't adequate evidence here to say that there's a net benefit. We thought that there was at least a small net benefit.
Right. All right, maybe now's the time to ask for anybody who's edging towards voting no, whether they would like to share how they are putting together the uncertainties and the findings. Anybody want to stand up for that side of the equation, or are we Dr. Wilt?
Thanks. Yeah, I'm nudging towards no. I'm nudging towards at least, there's not much juice for the squeeze here. David's comment is helpful for me, but I'm still struggling with what that means and the way it is being framed, i.e. add this to, quote, I'm going to call it standard of care. I mean, should we be adding a drug based on a study where everybody's saying is really perhaps not how we should be practicing, which has some burden? I know that's not benefit, but it has some burden in twice a day nebulizer therapy. I'm pretty convinced that there is some reduction in exacerbations, probably in those who, most seen in those who are exacerbation prone, and that's an important outcome. But I'm not finding a really meaningful benefit in quality of life or dyspnea or things like that for many patients is the main driver of why they seek additional therapy. And as illustrated by the original comment, patient comment, and by another aspect of why we use treatments. I recognize that exacerbations are bad and can have downstream consequences, but the modeling, as mentioned, seem to capture that issues of quality of life and dysfunction following an exacerbation, and even that appeared to be pretty small with that. So I'm leaning towards there's not much there in how we should be practicing care.
All right, thank you. Valerie?
As a patient, I gotta say, a 40% even possibility of reducing my exacerbations from the 1 to 6 I have every year is like a miracle. I have never heard of anything like this, and I'm really excited because I have tried all the therapies. I am on triple therapy. I've been on triple therapy for 20 years. And I'm really tired of having 1 to 6 exacerbations a year, and I don't know when the next one will make us have a permanent long-term reduction in my quality of life. I mean, I know I'm very lucky, and I don't know how much longer I can be lucky.
Thank you. Jimmy?
I was actually leaning towards no, but I guess that's the benefit of having patient experts until I had Valerie just speak and saying that 40%, it makes an utter difference in our quality of life. I think for me, that just swayed me over to the yes side.
Okay, thank you. Phyllis?
Thank you. I may only have 1 or 2 exacerbations each year, but if it takes me 3 to 6 months to recover from one, that's a significant burden on my quality of life. And so I think that anything that can reduce that for someone like myself who is prone to these exacerbations, that's a big deal. Yeah.
Great, thank you very much. All right, let's go ahead. Oh, Kurt, please go ahead. Then we'll take a vote after Kurt's question. Sorry. Kurt, go ahead.
Yeah, and for me, I'm still leaning toward no, because I'm still puzzled by this inclusion and exclusion criteria. You know, and even like a triple therapy, that therapy was approved back in 2017, well before this trial started, and so, that's kind of where I'm landing at this point.
Far be it from me to try to argue you out of your thought pattern, but just because, you know, health technology assessment groups run into this problem all the time where the trial is conceived in an era in which standard of care according to guidelines at the time say X, and in a weird way, they're almost hardwired into needing to follow that standard of care at that time, even if some clinical experts think that it needs to be kind of updated. So it's both the reality, but not necessarily the company's fault that they end up with studies using a standard of care that today we don't view as perfect or as what people would do. It's just part of the tension that you all have to think about in coming to this vote. I'm a little bit sensitive to the other votes we need to take within the hour, but I want to let you guys have your comments or questions, but we'll just try to keep them brief if possible. David?
Yeah, I just like to put this conversation into perspective. So table 9 shows the predicted lifetime exacerbations over time between two therapy. So 8.03 for the treatment, 12.26 for the control group. So difference is a 4.2 exacerbations, expected exacerbations over patient's lifetime, which I believe it's about like 35 years time horizons that the male might use. So if you're thinking about like relative benefit, it's still like relative ratio is 0.655. So about like 35% relative reductions. So still it reflects what we are seeing from the clinical trials, but from the absolute number of reductions in the exacerbations, it's a 4.2 exacerbations over longer 30 years time period. So you can, divide by 4 by at least 30. So it's very, less than 1 exacerbations over the almost like 0.3, 0.4 exacerbation reductions in a year scale. So I just like to put this result into the conversation that we are having.
Okay, thank you.
I just want to be cautious about thinking that this patient population in Mel's modeling had 35 years of remaining life. That isn't correct. And wishing Mel was there, or that I could call up the numbers fast enough. There we go. Mel, what's as Mel is eating there, what's the life years we're talking about here?
Yep, I'm pulling up life years this very second. It was definitely not 35. It was, now these are discounted 3%, but in standard of care, it was 7.7, and ensifentrine, it was 8.43.
So it's undiscounted, probably it's close to 10. So basically we are talking about 0.4 exacerbations reductions in an annual way.
Right. For this population with its baseline, if you will, rate of exacerbations, it's about, I'm very generalizing here, but it's about reducing by 1 exacerbation every 2 years. All right, Jill, you get the last comment before we vote.
Okay, thank you. I share a comment that Rachel put in the chat earlier, and that, it may not have been standard of care in the guidelines until 2022, but I find it odd that they specifically excluded the doublet and the triplet. Like, if they could have left them and we could have just pulled them in like they did with the rest of them, and maybe broken it out, understanding that it's not powered, but to specifically exclude them is odd to me.
Okay. All right, thank you. Everybody take a breath, pause, and now let's put up the voting slide. We have 15 voting members of the CEPAC, so please go ahead and vote. Is the current evidence adequate to demonstrate the net health benefit of ensifentrine added to maintenance therapy superior to that of maintenance therapy alone? Yes or no?
Help, I need to figure out how to get to the buttons. Thank you.
Okay, let's show the results, please. All right, 11 yes and 4 no. Thank you for what I thought was a very good discussion of some of your thinking. I think that helps make more transparent for the audience and other people who will read the results of this meeting, what you were thinking as you made your judgments. 11-4. Okay, let's go on to the next set of questions, again, which are in the general domain of what we call benefits beyond health that can be easily captured, if you will, in the clinical evidence, and then the values or special ethical priorities that may be important in particular ways. Now, we have voting questions that we ask every time that may or may not be particularly relevant for each drug, but we're going to run through them. The first question is, you're going to vote from 1, strongly disagree, up to 5, strongly agree with the statement, there is substantial unmet need with this condition despite currently available treatments. All right, and we've been talking a fair amount about this, but Mel, I want to come back to you briefly again. I know we have that shortfall information on the equal value life year gained. Anything else you'd like to add before we kind of pitch it back to the broader discussion around unmet need?
No, just to remind the panel of those estimates for absolute shortfall was 8.1 EVLYs, so 8.1 fewer EVLYs than the population, the general population. On a proportional basis, that's 54% of the remaining life, remaining EVLY.
And I looked through some, and maybe this was on your slide too, but in terms of if you're trying to benchmark that against other conditions, the absolute shortfall, and by again, shortfall means the decrement in overall length and quality of life is 8.1 on an absolute basis, and PTSD is 7.4, a topic that we recently looked at. That's one of the closer analogs, if you will, to the amount of quality of life lost with people with this condition. I always feel like it's incumbent upon us to hear again from patient experts, unmet need for you, for patients that you're aware of in your foundation and others. Would you like to just address that again as you see it?
I think sometimes we forget that each exacerbation can also end in death. I mean, not to be crass about it, but that is the thing we're talking about. And the other thing is, some of us are diagnosed at 42. That was me. I was diagnosed at 42. I had young children, and I am still around 24 years after they told me to prepare for a lung transplant. But I am exacerbating 1 to 6 times every year. And I sure would like something else. And I've tried everything, and I've had every side effect imaginable, and I am the side effect queen. But I'm really excited about a new therapy that could possibly have fewer side effects, because we have to keep tweaking. And some of us are in these therapies for decades, not years, decades. I might live another 30 years. My parents died in their 90s. I am in my 60s. Anyway, thank you very much.
Thank you again. Phyllis?
Thank you. Yes, I myself, even though I was diagnosed 9 years ago, of course, knowing what I now know, looking back, I had it at least a decade before, undiagnosed. So I would say that for myself and for my peers, this could be a game changer for us. The amount of exacerbations that could be reduced for us would greatly reduce the stress on families, on economics, on quality of life. Just being able to go and travel to visit family, to be at those family gatherings across the country, to be with friends outdoors, enjoying life and activities outside. So yes, I'm very excited and hopeful, and the unmet needs are very disturbing, extremely so. It's something that we're looking forward to.
Okay, thanks. Do you mind if I ask the clinical experts again too? If you considered the entire universe of patients to consider those that you already have on LAMA-LABA and inhaled corticosteroids. So if we're talking about unmet need, what % of that pie still has clinical kind of exacerbations and other features that you think represent an unmet need?
Say it's a lot. I would say, I mean, you can even look at the studies that a lot of people still are exacerbating and are certainly still having symptoms. So I'm going to say it, I may still have 30 to 50%, and I think that's a little conservative, who, but that where I might consider adding an additional, where I would potentially consider adding additional therapies, especially if we're thinking about, okay, is this actually potentially a therapy to add on even for just like symptoms, not just for exacerbations, which can also be really substantial and cause a major quality of life issue. And some of that I think of, just from having some experience with roflumilast, and can we actually understand a little bit about, patient experience with that drug, and just realizing sometimes it can really actually improve symptom burden and also decrease exacerbations in a subset of patients, but that we just don't like to use it because we're worried about the side effects. So it's kind of, to me, I'm like, okay, well, having something that I could easily add on and not worry about additional like side effects, that if we have something else to offer, we certainly have a very large number of patients who continue to exacerbate.
Okay, thanks. Now, Juan is, I think, finding a new Wi-Fi zone or something so that he can be better heard. But let me ask if any of the CPAC members have questions or comments before we vote.
Yeah, if I could just briefly comment, I think there is an unmet need, but I don't know if it's substantial in that the comment we just heard was from somebody who obviously knows about this a lot, but is in a referral population as opposed to in a primary care setting. And the patients I see are different than who I'm not having success with and who I need to have additional therapies. And all of those have gotten combination LAMA, and many of them have also gotten ICSs and or cannot tolerate them. So by the time they get to Dr. Christensen, they've gone through my whole gamut. And I was also going to say, outside of any symptom improvement from exacerbation reduction, which is important, we are not seeing evidence that it's improving day-to-day symptoms. In fact, that's what I tell my patients. Don't stop this, even if you don't notice improvement in symptoms. It's designed to prevent the exacerbations, like an aspirin a day. But if it's not improving exacerbations, then it ain't helping, because it's not helping their day-to-day symptoms. So thanks.
Okay, thank you. Stephanie, do you want to comment on that?
I just want to say that it's a really good point that we see different patient populations. I think that's true. I think I would just say that there's just so many patients with COPD that if you've got, an ability to help, even a subset, it could be potentially great. But I totally agree with you. I think there's also, I see this more and more where people don't want to put people on inhaled corticosteroids. I still am always telling them to do it, but particularly if they have bronchiectasis, so COPD and bronchiectasis together, so they're at more risk for getting infections, and we see that a lot. Because we get more CT scans now, so people are worried about getting concomitant airways infections, or are worried about antibiotic resistance, or I'm sorry, worried about pneumonias and having to put people, so I think I actually think it's overblown, but I think I think there is some of those issues too, just thinking in real world populations. But I totally agree with you that you see a different patient population than I do, and you may get a lot more benefit from some of those therapies. They can be life-changing for a lot of people.
Great, thank you again. Okay, that's great. Let's put up the voting question on this one. Again, voting from 1, strongly disagree, to 5, strongly agree. How do you react to the statement, there is substantial unmet need despite currently available treatments for this patient population? Please go ahead and vote. We have one person who's wrestling with the technology. We should have 15 votes. There we go. Thank you. Let's see the results. Okay, 9 agree. I can't even see the bottom on my screen. Apologies. Somebody else is gonna have, can't see the bottom. There we go. Strongly agree is 4, I'm thinking.
It is
Yep.
4, yeah.
Okay. And disagree is 2. All right. Okay, let's go ahead to the next voting question, which is, this condition is of substantial relevance for people from a racial or ethnic group that has not been, people who have not been, I should say, equitably served by the healthcare system. And you're going to vote from strongly disagree to strongly agree. And Grace, could you again remind us from the report findings of the relative prevalence of COPD in different racial and ethnic groups, and we can then open it up to discussion.
Yes, Steve. So the main group that there was a disparity is that in Alaska, natives and American Indian, they are disproportionately affected based on their population, based on population size. And so that was the only population that's where the prevalence was substantially different from the general population.
And I was actually surprised when I saw the number. We calculate this number called the Health Improvement Distribution Index, or HIDI. And anything above 1 means that you've got a subgroup with a higher relative prevalence to a certain extent. And the number, 1.7 is a fairly large number. Is there any understanding whether it's biological or it's some other kind of environmental situation that leads American Indians and Alaskan Natives to have a higher prevalence? Anybody know? Maybe clinical experts, if not the team.
I think the rates of smoking are very high in that population.
So it's not adjusted for smoking. Is that? Okay.
That's correct. It's not, no.
Okay. Jill, go ahead.
So I just don't know the answer to this question, but does that population that is affected with the 1.7 HIDI score have, are they not equitably served? Do they have a disproportionate lower access to insurance and healthcare than the white people and the Black people and the Asian people who were included in this trial? Or, are they disproportionately not have the same access?
Well, in terms of the prevalence of COPD, access itself probably wouldn't have too much to do with it, if you will. But I'm not sure if you're asking about today or whether they have suffered, if you will, from historical inadequacies in, access to healthcare.
I'm just looking at the question because it's kind of twofold. It's like, yes, the condition has a substantial relevance to a racial ethnic group, clearly by what Grace presented. But my second part of that question is, are they not adequately served? Are they at a worse, do they have worse access than the rest of the country? So that's kind of a two-part question on that.
I'm sure the team thought about this. I'm certainly Indian Health Service has had chronic underfunding and other issues. And I think a lot of people would believe that they do not have and have not had adequate access or comparable access to other people in the country. How to make other cross comparisons. And I know much less about Alaska Native healthcare, to be honest with you. Tim, go ahead.
I just pulled up the Kaiser numbers really quickly on the insurance rates by race and ethnicity, and the uninsurance rate for that group is 19%, which is about 3 times higher than the national average. So.
Okay. Rachel?
I know that there's a lot of interest, including by the FDA, to have more diverse enrollment and representation in clinical trials. Am I correctly reading the enrollment numbers to show that there was very little representation of those particular populations, if any, in the trials that we're looking at here?
Good question. Grace or team?
That is correct. The trial was 92% white.
And not just 92% white, but I'm looking for specifically the populations with higher prevalence, the American Indian or Alaska Native. It looks like there's very, very low.
Very, very few, if any.
Okay.
I think it's worth our highlighting that in the final report. I think that's part of the reason that we are also calculating a number related to kind of representation in the clinical trials, that's an important issue. Tim?
Yeah, so from my perspective, it would be important to get better representation, but I think it's unlikely that there is racial, ethnic effect modification of the treatments. So for me, that's not a major factor in my voting. It's really whether there's a large demographic that's not getting access to the care in the overall group, unless we have some a priori reason to think that somebody of a different race or ethnicity would respond differently, be it benefit or harm to the treatment. And I really have no biologic reason as to why they should. So I would use a standard effect measure and think about that across a whole population and figure out whether we're getting that therapy appropriately so to the various populations.
Fair enough. I do want to point out that in framing this question, we do intend to capture environmental conditions that might lead to a higher prevalence. So it's not that we should be ignoring environmental factors. Asthma, for instance, we know has higher prevalence in some inner city populations for environmental reasons. And that may mean that decision makers want to prioritize treatments for that condition, if only because we have kind of a historical problem with disparities that are due to either biological and/or environmental situation. Stuart?
So I'm interested in this drift that we go in these two questions from the prevalence and the meaningfulness of the condition to actually something about the drug or the intervention. And I interpret these to be just as they're written, is the condition of substantial relevance. And so I think the prevalence answers it really quickly and easily.
Okay. You're correct. We're not asking you in this question to consider the relative effectiveness of ensifentrine. Those questions are coming right up next. Stephanie?
Just to kind of give you our being able to diagnose COPD, so actually diagnose, and probably for a group that's going to get this drug, you have to have spirometry. And so globally, in underserved communities, there's a lot less access to those kind of technical things. We put a lot of people on inhaled corticosteroids and on inhalers just because we throw it at everybody, even when they don't meet the technical criteria. But if you're talking about to even get a diagnosis of COPD, requires that you have access to things that access to testing. And so that in communities where that's lower, or in countries where that's lower, you're going to have lower prevalence of the diagnosis.
Okay. Great. Let's put up that voting question again then. And again, please make sure you've got the scale headed in the right direction in your mind. 1 is strongly disagree, 5 is strongly agree. And the question is, well, sorry, you're reacting to the statement, this condition is of substantial relevance for people from a racial ethnic group that have not been equitably served by the healthcare system. Go ahead and vote. All right. We have 8 agree, 5 neutral, and apologies again, I cannot see the bottom, but I'm doing the math and I assume 2 people said strongly agree. All right. Good. Let's move on to questions now that do ask you to think about the relative effects of ensifentrine. So let me read this preamble. To help inform judgments of overall long-term value for money, please indicate your level of agreement with the following statements based on the relative effects of ensifentrine added to maintenance therapy versus maintenance therapy alone. And here's what we're trying to at least admit the possibility that there are broader or spillover effects that decision makers should consider when they're thinking about value. So the next slide is one of them. And that is the treatment is likely to produce substantial improvement in caregivers' quality of life and/or their ability to pursue their own education, work, and family life. Again, as I said, we ask this question about every single drug. Sometimes, we're talking about treatments for children around which, caregivers are extremely important and affected by their condition. Sometimes it's less so. But in this case, we want to think about COPD and the relative effects of ensifentrine and what you think the spillover effects might be. And so from strongly disagree to strongly agree, we'll ask you to vote on whether it's likely to produce substantial improvement. All right, let's talk about this one. Patient experts again, or clinical. It's probably an up or down things. We talk about exacerbations, but it's also, a chronically worsening condition. Tell us from your perspective what that means for the caregiver impact. And again, the CEPAC itself can kind of factor in how much of a difference they think ensifentrine will make for the patient and by extension for those caregivers. But let's hear about how caregivers are affected. Valerie?
Well, I was a caregiver for my father, and my husband is my caregiver. When I was 42 and we had 2 young children, every time I got an exacerbation, the world kind of stopped for me. And so he had to pick up all the slack. And he never complained, but he was never happy about it. And every time I have an exacerbation, especially when we're traveling, because we travel about 30,000 miles a year, we always wonder, am I going to be stranded in Okinawa, in Oklahoma City, at some remote region because I can't convince the airline personnel that I'm healthy enough to fly? That's an added problem when we have exacerbations. And either we stop our life and just stay in hibernation, or we try to do whatever we can to optimally manage, including adding on something to our triple therapy to maybe possibly have fewer exacerbations so that our loved one and caregiver doesn't have to pick up all the slack for us. Anyway, thank you.
Sure. And Phyllis, or clinical experts, I mean, you may have your own experiences certainly of working with families, and what's the experience of a spouse watching their loved one have difficulty breathing and the relative effects on them?
The experience of a spouse dealing with a loved one who is having an emergency, who's in crisis with their breathing, it can be devastating if they don't have any medical background. I'm fortunate in that my partner is a retired EMS paramedic. However, most of my peers do not have a medical professional as a spouse or partner. So it can be very scary for a caregiver. It increases the burden on their mental health, and their mental health transfers over to the patient, and it goes back and forth. I'm just coming to you as a person with 25 years helping the mental health community. So yeah, it's a back and forth situation. And it puts a great burden on both the physical health care of the caregiver and the patient, and the mental health care of both. And that's my whole world view of it.
Thank you very much. I appreciate your sharing that. Okay, let's go ahead and put that voting question up. We have one more after this one. I'm sorry, Kurt. You're always very polite, and then I always cut you right at the end. So go ahead.
That's fine. So thinking back to David Rin's comment, I find that very interesting in making this vote, because, quality of life at 12 weeks and 24 weeks, it's mixed. But day to day, what's the impact? And it might have a positive impact based on its mechanism of action. We don't know, and I would love to know. So anyway, it's a bit mixed for me.
Yeah, and I think it's completely fair to think about this from different perspectives. One is the day-to-day effect on quality of life and how that spills over to caregivers. The other is, even if it's once a year and it, reduces the risk of an exacerbation or shortens it, that it's kind of the chronic versus the periodic effect on both patients and their caregivers. So thinking about both, I think, is completely fair. All right, so why not? We go now back to the voting question. So remember, again, strongly disagree is 1, up to strongly agree is 5. The statement is the treatment is likely to produce substantial improvement in caregivers' quality of life and or their own ability to pursue their education, work, and family life. Go ahead and vote. All right. 10 neutral, interesting. We have 3 agree, 2 disagree, and that is the 15. Okay. All right. And I think from our discussion, we're all aware that I think those votes are, again, that combination of factors, the relative effects of ensifentrine and, the kind of judgment of how much there is a spillover for caregivers. All right, this is our last voting question. Since we do not have a price for this treatment yet, one that we feel that it's fair to have a public vote on, we are not going to have a CEPAC vote on the overall long-term value for money, but we do intend, again, for these votes to be important to decision makers when the price is available and a final judgment can be made. So the last voting question for today is strongly disagree to agree. The treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery. So now we really do have to kind of get into the real world again. This is a nebulized treatment. Let's talk about whether its method of delivery, that it's nebulized as opposed to an inhaler, for instance, does that offer a substantial opportunity to improve access to effective treatment for folks? So let's take down this voting slide. Let's ask the clinical experts that first today. Are there, again, given the pool of patients that at least you care for and that you might imagine in the community, would having ensifentrine enable access to a group of patients that would have struggled to gain access to it before, to effective treatment before, or not really?
Yeah, I think it will on a marginal impact type of calculation. Just thinking about colleagues who refer patients to me and or my own patients, there are especially those with concomitant rheumatologic arthritis or severe hand arthritis that have limitations with inhaled therapies, such that they have to have family members help them, or potentially it's not even possible because they have no one around. And that's often when we think about moving towards inhaled therapies via nebulizer solutions, kind of exclusively for that patient population. And right now, kind of the hoops that both primary care doctors and pulmonologists have to go through to get those approved are kind of more laborious, and sometimes more limited options in that space. And so I think for those patients who have specifically either a combination of cognitive issues that could lead them to have trouble using MDI or dry powder inhaler, issues around the musculoskeletal system, I think this could be an option for caregivers to sort of be the facilitator to put the solution in the med machine and then allow them to take that therapy daily and potentially, in this case, limit, potentially their exacerbations and time will tell whether or not quality of life, meaningful quality of life things will improve. But I think there is a small but not insignificant patient population that would benefit from this new inhaled nebulized therapy that doesn't currently exist.
Okay. Welcome. Any other comments from Stephanie or others? Any questions or comments from the CEPAC as well? Please raise your hand. Valerie, it looked like you wanted to say something.
I think it's underestimated how much medicine that patients get on the carpet or in the air when they have poor coordination or dementia as they age. And I think nebulizers have been shown to deliver a higher rate of the actual medication to the patient's lungs than some of the other delivery methods. Study after study keeps showing that patients are not optimally using inhalers. And even though it's a slight inconvenience to use an inhaler, use a nebulizer, I'm happy to use it if I know it's going to help possibly reduce my rate of exacerbations. And I think a lot of patients are in that category, especially when they're already having a very low inspiratory flow. So they have a hard time getting all the medicine where it should go. Thank you.
Thanks. Tim?
Yeah, so the question reads a substantial opportunity. And what I'm hearing really is on the margins with that. So I can't see this as substantial opportunity. And again, mechanism of action doesn't influence me too much. I want to know whether something works. And the fact of the matter is, in this situation, many of the patients were not on optimal therapy. So I think that there may be marginal areas, but I don't see it rising to the level of substantial.
All right, thank you. Kurt, you're learning to get in there earlier now, aren't you?
Yeah, I have a couple questions. So the first is there any affordability issues as far as the nebulizer device? I'm assuming it's fairly inexpensive, but I just wanted to check on that. And the second thing, putting my pharmacist hat on, is this going to be a refrigerated drug? And if so, maybe that might, I guess, make it a little more difficult to be able to do this routinely.
Maybe the clinical experts would be best placed to answer that question.
I can answer the nebulizer question. I guess there are two options for nebulized kind of therapy. You know, if you're a new person getting that prescription through sort of your durable medical equipment referral that I can make as your pulmonologist through your insurance. I have a lot of patients, those from the variety of socioeconomic statuses, that also like to have portable options. And so they have, gone to the, Amazons of the world, if you will, to find a kind of portable battery operated med treatment to have in their purse or in their bag when they travel, even at pretty minimal cost. We're talking like between $30 and $50 now these days. And so I think from a device, getting a nebulized device is fairly low bar to get, even for those who have a very limited budget.
Yeah, and does team will know this? Does this need to be refrigerated? The solution for this, I assume it does.
I
Anybody?
am not sure. I don't think we have that information, actually.
Oh, interesting. Stephanie, do you know?
I don't know, but you typically these drugs haven't been refrigerated,
okay.
so that would be. I mean, I don't know about this one, but typically our nebulized solutions have not.
Yeah,
needed
most
that,
are not.
so.
I can't think of any that are.
Yes, I'm sorry. You're right.
Yeah.
You just squeeze it into the, yeah, in plastic. Okay. Given the time, I'm going to move on to Tim's last question, and then we'll take a vote. Tim.
Yeah, in interpreting this question, and I know we're not voting on value because we don't have a price, but I'm going to sneak this in anyways. When I look at this question and the words that are in it, I am having a hard time voting without thinking about price, because it would matter a lot, whether it's $18,000 or $7,000 or $2,000. So you're about ready to throw a pen at me, but how do I deal with
See
that?
what does it look like? I'm about to say that's a great question, and I have an easy answer that's not easy to do. The easy answer is I want you to strip consideration of the price out of your thinking when you vote.
Oh my God.
No, it's the other pieces of it. I mean, Kurt's question was fair game, because if it's a hardwired cost to get it, that the nebulizer itself costs $3,000, that we would want to consider, because that would certainly not make this an easy way to expand access. Similarly, if the delivery mechanism was much cheaper, we could say yes or no. You could say yes to that. But in a sense, I want you to think about its mechanism of action and delivery more than the price that will be attached to the treatment, to the drug itself.
All right.
All right, because
I'm just grumbly about that, as you know.
I know, because this is supposed to be that kind of ancillary question at the margins of what everyone's gonna focus on for sure, which is the price. And we'll talk more about that on the policy roundtable. All right, with apologies, if anyone else wants to say anything, I do want to go ahead for the vote so that we can have a break before the policy roundtable. So please go ahead and vote from 1 strongly disagree to 5 strongly agree. Your reaction to the statement, the treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or delivery. And we have an answer being 8 neutral, 4 disagree, and 3 agree. Okay, thank you very much for that vote, for all the votes. Let's go ahead and take, we'll take a 9.5-minute break so that we can start at the hour. Want to make sure that we have